that some of you may already have heard about in previous engagements. Please help me welcome both Larry and Cindy.
There we go. Sorry about the delay. The PowerPoint that I had sent didn't get loaded into the system, so we are creatures of our technology. This talk will be in two parts. I again apologize that my portion of the talk didn't get turned into a handout, but we'll make the best of it. My name is Dr. Larry Otteman. I've been a medical oncologist here at McFarland Clinic for over nearly 27 years, and I've recently become board certified in hospice and palliative care, but for the last 27 years I've also been involved in the hospice program. I am the medical director for the Mary Greeley Medical Center Palliative Care Program, and it's under that hat that I give this presentation. It'll be in two parts. The first is to simply understand where the McFarland Clinic Advanced Directive came from, and to give credit where credit is due. The second is to understand about the iPost, and that will be Cindy's portion of the talk. And we'll talk about where you can find both of these resources. Not a very complicated discussion. I want to begin with a little bit of the historical background for advanced directives. Justice Cardoza in 1914 stated what remains, at least from the Supreme Court and all other courts below it, the standard for conscious adults to determine their own care. In his words, every human being of adult years and sound mind has the right to determine what shall be done with his own body. That's a principle in 1914, and that remains the bedrock principle. Of course, it goes back centuries, but that's the American legal background. Karen Quinlan, 1976, was a young woman who was in a permanent vegetative state, and her parents sought to remove her from life support and artificial feeding. And then the Natural Death Act in California shortly followed thereafter, in which the living will, which had been around for a while, was given the force of a legal document, that it had legal standing and that it was binding on providers. The McFarland Clinic Advanced Directive was first written in approximately 1990, and it was based on an article that was published in the Journal for American Medical Association in June of 1989 by Dr. Ezekiel and Linda Emanuel. Both remain quite prominent in this field. Dr. Ezekiel Emanuel is the director for ethics at the NIH and also at Yale, and Dr. Linda Emanuel is one of the founding members for training for something called EPIC, E-P-E-C, not the EPIC we all know. The 5 elements of the McFarland Clinic Advanced Directive are taken directly from Dr. Ezekiel's and Linda Emanuel's paper, and they are, if anyone happened to pick up a copy of the Advanced Directive, but they are pretty simply a page of explanation, the living will, that is a legal document in the state of Iowa, 4 scenarios and specific interventions, yes or no, and a page was added for organ donation, and then also the paperwork necessary for someone to designate a durable health care power of attorney. Taking from the paper by the Emanuels, the weaknesses of living wills were recognized as soon as they were constructed, and for any of us who have looked at living wills, they are incredibly vague and difficult to say that they give providers or even family members very much direction. Terminology such as irreversible coma, definition of terminally ill, and you can read on and on. And so the Emanuels felt that this was a true weakness. It was so vague to not be helpful when it really came to crunch in terms of whether to do this or that procedure and so on. And this is their critique. The problem of existing living wills, which is lack of accommodation for positive requests, that is, people couldn't say, I do want this done. Linguistic vagueness, being inflexible, and a poor communication tool could all be substantially relieved by use of their medical directive as written in the journal. They then devised this idea of using scenarios so that people could sort of have a thought experiment. What would I do if I were in this position? And those scenarios were defined not by a diagnosis, so there wasn't a, you have cancer, you have end-stage renal disease, but in fact it had more to do with what their level of disability was, whether their mental faculties affected, what the prognosis was. As in surveying the literature, those seemed to be the critical factors. Interestingly, these four scenarios also were the same cases which were then very well known in the legal literature, the Quinlan and Brophy and Dinnerstein, Conroy and Spring cases, all of which have to do with legal rulings on limitation of care provided through patients who couldn't speak for themselves. A strength of the medical directive was that it used both affirmation and rejection of very specific treatments. So one could answer the question, if your father found himself in this position, would he want this done? And the document does address that quite nicely. Now, they acknowledged, since our document at the McFarland Clinic is drawn from their document, we would acknowledge that there are unavoidable vagueness, but much of the vagueness has to do with our inability to prognosticate very accurately for family. And so the vagueness of the document is a feature of what we're asked to do, which is to guess how long someone might survive, and not a vagueness of the wording, which was the fault of the standard advance directive. It is detailed enough that a provider should not, or simply hand it to the patient without any review of what the terminology means or what the patient intends. So this isn't one of those things where you can just hand it out at the end of the appointment and have the patient turn it in like a homework assignment and not look over it with the patient. There's a criticism that because there is a column for yes in terms of intervention, that the document forces providers to provide futile care, and that's not true, although there's an ongoing argument about, of course, what futile care would consist of. And it does not carry the force of law. That is, there is no legislative body which has looked upon any advanced directive with regards to details, whether the manual model, which is used at Harvard, or the McFarland Clinic, which is based on that model, or things such as 5 wishes and so on. None of that has the force of law. But what does carry the force of law is the underlying principle enunciated in 1914 about the right of self-determination. The manuals studied their document after it was constructed and utilized at Harvard and Dana-Farber. And they studied 405 outpatients and then a general public survey, as you can read. It turns out that the vast majority of people actually are interested in stating what their wishes are, and that there was really very little variation between the age of the patient or even the health of the patient in terms of wanting to state what their wishes were. In general, about 70% of the population decides against aggressive intervention, given the particular scenarios that are found in the advance directive, if they imagine themselves as incompetent with a poor prognosis. So unlike the current default position, which is if a patient can't speak for themselves, our assumption must be that we do everything, so that their silence is interpreted as no choice but to do everything. If you actually poll patients, the best guess as to what someone would want done would be that they didn't want something done. But obviously 70% is not 100%. These are the barriers to that discussion, which still doesn't get done in many offices, my office included. That most patients aren't going to discuss this on their own unless the physician brings it up. Many people say, well, it's not really relevant to me because I'm not sick or old. Some people don't even think about that they'll ever need to be faced or that their children will be faced with this decision, and the others are less common. I will indicate where you can get more information, and this is part of the third objective, which is where resources are. Every department in the McFarland Clinic and every nursing station at Mary Greeley has these McFarland Clinic advanced directives available. The clinic makes these available to bankers, attorneys. It's not a protected document that we somehow have a vested interest in preventing it from being used. So we're trying to disseminate it as widely as we can. I have recorded a video on the McFarland Clinic website that we certainly would encourage you to direct patients to. It's not necessarily a how do you fill out the form, but more a discussion about why should you take the time to fill out an advance directive. And that's something that's available through the McFarland Clinic website. Again, for the document to be effective, you really do need to discuss this with the patient when they return it to the office to make certain that you understand and the patient understands what they are requesting or saying no to. And then it will be scanned into the EPIC electronic record, the EMR, under the Media tab. I will be happy to answer questions at the end of the discussion, and now it's Cindy's turn to talk a little bit about iPost. There we go.
Thank you. Many of you have heard about iPost already, and some of you will be hearing about it for the first time. The conversation about advanced directives and getting people's wishes honored really has continued to evolve. We're talking about something that started in 1914, and now we are almost 100 years later, and we're still evolving as far as our ability to do this. And the iPost is a new tool that we're going to talk about today that will help take a person's advanced directives and put them into a usable tool that travels with the patient in all settings. So what it is a variant of the physician's orders for life-sustaining treatment. The PULSE movement, which is a national movement, was pioneered in Oregon in the 1990s. And this POLST movement was an effort to convert the advance directives into actionable physician orders. And to date, 14 states are POLST endorsed and 24 states are seeking that. Iowa has met the first component of being a POLST endorsed state by instituting the iPost. There is more to come to be POLST endorsed, so the pilot project group in Eastern Iowa is really heading that up. So how did this project get started? In 2008, the Iowa Department of Public Health basically said to the legislature, we want you to mandate this study because we believe it's important for the state of Iowa. So a 4-year pilot project was funded. The people in Lynn County were ready and willing to take on the challenge to do the pilot project. It did end recently, and based on the results of that 4-year study, the Iowa Department of Public Health did recommend to the state legislature to do a statewide rollout. And extensive research indicates that healthcare providers honoring a POLST greatly improve the utilization of advanced care planning and adherence to expressed wishes. If you want more information about the overall national movement, you can go to this address here for the research that has gone behind the national POLST movement. The intent of the iPost then in Iowa is to create a uniform but portable physician order set that allows patient preferences and treatments to transfer from care to care setting with the patient. It travels with the patient, it's owned by the patient. The idea is to consolidate and summarize their wishes regarding life-sustaining treatment or interventions into actionable physician orders that complements the advance directives but doesn't supersede it. And this is not for everyone. The advance directives, the McFarland directives, things that you typically see out there are available for adults. This is a particular tool that is limited to a particular population, and I think that's really important that not everyone is appropriate for an iPost order set. It is the chronically and seriously ill person in frequent contact with healthcare, person with a life-limiting illness, or the frail elderly. And the frail elderly, of course, is an enormous population group in Iowa. And it also may be used for children. It's not restricted to just adults. So the first thing to remember as providers is not everyone is going to be appropriate for an iPost. You must fit one of those 3 categories in order to have an iPost. It's a standardized form. When you came in, you probably picked one up on the table. And we're going to talk a little bit about the actual form. So if anybody doesn't have one, raise your hand and we'll have somebody pass them out. Everybody got one? Okay. It's quickly understood. It's simple language, easily understood by patients, healthcare providers, and emergency personnel. It is not meant to take the place of advance directive. It is meant to complement and put it into physician orders valid in all settings, and of course, like any other advance directive, it can be revoked by the patient at any time. This is the top half of the front page, and I'll just hit a few highlights of the form. This is one of those pieces of paper that we're going to have to keep track of. And the first thing that you think of when you have a piece of paper, an electronic medical record, is, okay, how do I get this in Epic? And the answer is you don't. This is owned by the patient. It travels with the patient. It is not going to be scanned into Epic. So it is going to be a challenge for all healthcare providers in all settings to get into the habit of sending these to and from the hospital with patients or long-term care residents. So the top of the first page talks about code status first. The next section is medical interventions. You can read through those. We're not going to hit all of those, but I do want to draw attention that in the bottom of section B, there is a line for additional orders. And this is where it really does complement either the McFarland directive or a person's 5 wishes or living will. whatever the specifics are that aren't covered on this page are going to be put into that line in section B. And one of the things that was discovered in the Eastern Iowa pilot was that there was a fairly large percentage of frail elderly in long-term care who did not want to be sent back to the hospital for every complication that came up. And that was kind of a surprise to the pilot group. But I guess if we stopped and asked 95-year-old little old ladies in the nursing home what their goals are for their health care, we might be surprised by their answer. So that was something that did recurringly happen in the pilot group, was those people who chose not to return to the hospital. Section C is the nutrition hydration section. Patients can pick their choices there. And then the bottom half of the page is basically who's making this decision. Is it the patient? Is it their MPOA? Is it somebody else? Now this is the same hierarchy that's in the statute for the Code of Iowa on who can make decisions if the patient's unable and hasn't specified someone to do that for them. And then another part that's really important is the physician or the nurse practitioner or physician's assistant who fills this out or who signs this for the patient must really indicate the rationale for the order. So that section is pretty important. Whether it's the actual patient who fills out their own or a healthcare professional who assists them, the physician, PA, or nurse practitioner must make sure that one of those is checked in that section. At the bottom of that page, it has a physician signature, a place to print it, phone number, and then the person who, a patient or their legal representative who signs it. On the back page are sort of some instructions. So if you flip over the form, you'll see some additional information on completing it, how to use it, how to void it. This is no different than any other advance directives. If the patient chooses to change it, they can. Our recommendation is if the patient changes it, please destroy the original and create a new one. How to get it from place to place. It must accompany the patient between all care settings. And then there is a place which was actually added by the Department of Public Health later. This was the last version, which has a place at the bottom for reviewing. So if you are the provider and you are reviewing this with your patient at clinic visits, there is a chance there then to date, and so that you'll know it's been updated or at least been reviewed. This would be particularly important if the patient has a significant change in condition, perhaps a new diagnosis or a life-threatening illness, and their overall prognosis may change. Now at the very bottom there's a place for whoever helped them fill out the form if it wasn't the patient themselves. They do recommend that this be nurse, social worker, chaplain, or someone who has enough information about health care that you can help people understand the consequences of the choices that they pick, and also enough about the patient's medical history to know whether or not they qualify to have an I-post in the first place. So that's the actual form. They're going to be available in the clinics. They'll be available on all of the nursing units at Mary Greeley. They'll also be available in case management department at Mary Greeley. But anyone from the public simply can download it off the Iowa Department of Public Health website. So you may find people coming in with one on white paper. If it's on white paper, you know they downloaded it themselves, which is perfectly fine. The statute does say that providers must provide it on brightly colored paper. So, thus the brightly colored paper. If somebody does scan it into Epic accidentally, at least it'll show up. You didn't use a dark color. So, okay, guidelines. You can get it at this website. Just type in the word I-post when you get to the search. Can be filled out by any of those people we just talked about. And again, it must be someone who has sufficient training or knowledge to be able to explain the implications of the treatment choices. That's very important. And by the way, there are some people out there in this area who have already done this and are bringing them in with them to their physician visits. So it's not a secret. We are working very hard to educate physicians and Mary Greeley staff during the month of October. We will be fully live with all the changes in Epic on November 1st. Those are the 3 groups that can sign it. This must stay with the patient and travel with them. Now, if you are a provider and the patient comes into Mary Greeley with an iPost, we have put in an order set into Epic so that it will make it easy for you to transfer the paper orders into Epic. You go into order entry, order sets, type in iPost, and then this form basically appears. Also, if a patient comes in with an iPost through the ED has a screening question so that if the patient does in fact have an iPost and they click yes to that assessment question, then patient has an iPost will appear in the banner at the top of the page. And if they are not admitted through the ED, the same principle applies on the nursing assessment on the units. If they click yes, the patient has an iPost, then that will appear in the banner at the top of the page. This is important. This is kind of one of those things that as a hospital and clinic system we don't think about this very often. But any physician, DO, nurse practitioner, or physician assistant that is licensed in the state of Iowa can sign an iPost and it becomes valid. If someone comes in with an iPost that is not signed by a physician who has Mary Greeley privileges, it is still a valid order set. That's why it needs to be transferred into Epic. So just because it's somebody who doesn't work at Mary Greeley doesn't mean it isn't a valid iPost. It is a valid iPost and should be honored. So we tried to make that easy by creating that order set. If the physician is unwilling to comply with a valid iPost order set for whatever reasons, they should take all measures to transfer that patient's care to another provider. Can't imagine that would happen, but there's a provision for that. And the iPost does not supersede any of the medical decision-making hierarchy that's already established in the Code of Iowa. And if the patient already has an out-of-hospital DNR, which a few people do, it does not supersede that. If someone's gone to the trouble to get a physician's order to have an out-of-hospital DNR, which currently in Iowa is only available to terminally ill persons, then the iPost does not supersede that. If they have a DNR order in their home, on their person, that's the highest priority. And the paramedics are aware of that. And any patient who should die from having an executed iPost does not consist of a suicide, homicide, or any kind of adult abuse. So there are protections that are built in to the bill for the state of Iowa. Also, you cannot require a person to have an iPost. That's pretty self-explanatory. This is something the patient should choose to do, or if they're unable, their medical power of attorney should do that. And you should not assume the intent of a patient who does not have an iPost. This is brand new. It's going to take months or longer for the general population to have a knowledge about the iPost. You can't assume that because somebody does not have an iPost that you know what their wishes are. And it shouldn't restrict anybody's ability to make their own legal or medical decisions. If the patient can make their own decisions and they're competent, they decide. If they cannot, their medical power of attorney. If they don't have one, there is a list that we just saw that governs who can make decisions. Other protections for physicians: the iPost is not construed to condone, authorize, or approve mercy killing or euthanasia, and to permit any affirmative or deliberate act or omission to end life other than to permit the natural process of dying. One of the things that we would like to see as we continue to evolve in doing excellent end-of-life care is to use language with patients and families to allow a natural death. And that's actually some healthcare groups are actually using that order, A and D, allow natural death, in some of their documentation. It tends to normalize the process for patients and families. It gives you less of an idea that you're taking something away, like resuscitation, if we in fact acknowledge that the person is going to die, let's allow it to happen naturally and let's keep them comfortable. Sort of the hospice mantra. If you are initiating a new I-post at Mary Greeley, that would be part of the discharge planning process. And we do recommend that if you are the discharging physician and you want them to go out of Mary Greeley with an I-post, that you start that before the day of discharge. And the reason is, as Dr. Otteman said, this is not a checklist. The medical directive, the I-posts are not checklists where you just have people fill out a form. It is a discussion. It is a discussion about what their understanding is of their current condition. It's a discussion about what their goals for their health care are at this point in time. And it is a discussion on making sure that each of those options on the I-post are discussed so that they understand the consequences of them. It is not going to be a 2-minute conversation. So the nurses, social workers are the people most likely in the inpatient setting to be assisting with these. But you need to sign them before they leave the hospital. So if you wait until the day of discharge, it's not something you can sign in Epic. So just think about the discharge planning process. You might want to start that a day ahead of discharge. In the office setting, the I-post will be available in all of the clinics. You can certainly have any of your nursing staff be the designated person to sit with someone and go through the I-post, have the discussion about their current condition, what their goals are for their care, and help them understand the consequences of the things they check on the form. So, a few frequently asked questions, and then we'll get to your questions because you'll have some. Are they going to be required for all patients and for long-term care? No, they're not. There are going to be some people who are highly motivated who want to make sure that their wishes are honored in all settings. And those are the people who are most likely going to be the first people requesting an I-post. Once we get long-term care education completed, I think we'll have a group of people in long-term care who will feel strongly about having an I-post, and then creating a process for long-term care where this piece of paper comes in with them and then goes back out with them. Now in eastern Iowa, what they discovered was long-term care facilities did a great job of getting the I-post to the hospital. They never got it back. So then it had to be redone. So we're going to be better than that. We're going to make sure our processes are such that if they come in with an I-post, that it goes out with them. We've added a question to the discharge summary to make sure that that is addressed as part of the discharge process. So that should help. Does an I-post replace or revoke an advance directive? No, it is meant to complement it. It is meant to take their wishes and put them into actionable physician orders which travel with the patient. You need to know the process wherever you work, whether it's McFarland or Mary Greeley. And if we don't have a process in place for I-post, will we be legally able to initiate or comply with I-post orders? Well, if we don't know what we're doing, that's going to be really tough. We don't want anybody to bring in an I-post, hand it to somebody and say, well, I don't know what that is. So in the month of October, we really are working with all points of entry into Mary Greeley, whether it's patient access, whether it's somebody who who goes from ED to lab or radiology, and then goes to the inpatient unit, whether it's ED to ICU. We want everyone to know what it is and what to do with it. If a person brings in an I-post from another state that isn't exactly like Iowa's, is it valid? Yes, if it meets all the conditions for the POLST requirement, for POLST endorsed states. So we will get there. And likewise, if an Iowa I-post goes to another state that's POLST endorsed, it would be valid in that state. And you can tell by the numbers, 14 states already have it, 24 are seeking it, that eventually this is going to be pretty common across the country. Now, questions? Yes. Well, that's an excellent question, and you're not the first to ask it. The reason that they don't recommend that you scan it into your medical record is because no one will know it's there, and no one will look for it. Plus, it belongs to the patient. It's to travel with the patient. You would be able to go look at a previous admission in the encounter to see the iPost orders that were there, so you could retrieve it if you were highly motivated. But for reasons of risk management, both McFarland and Mary Greeley, and this is consistent with the pilot project in eastern Iowa, is if you scan it into the medical record, it's lost, no one will look for it, and it won't help you do what we are in fact trying to do, which is honor the patient's wishes. So while that seems a step back in time, and in some ways it is, because everything's electronic, we really have to train ourselves that this piece of paper is part of the patient, and it goes with it. So it's not going to be scanned in after. You want to add anything, Darla? Right. And you shouldn't amend it, you should destroy it and get a new one. Okay, good, thank you. Yes.
They move them to the hospital. I mean, it's going to be, I feel the same way Lynn does, that if at every facility that you go to should copy it and give it back to you so that it's there for everybody to see. And then when you're dismissed, erase it. But I'm not going to be carrying this piece of paper around with me. So how do you address that?
That's really the point behind it being an order set. If someone comes into the hospital with their list of medications, as all of our patients have their list of medications, of course. But if they come into the hospital with a list of medications, we don't say to that person, well, you've got to carry your list of medications every time you go to a different department. How do we know what you should be on? Doctors and nurses write an order for the medications that they're on. So if you want to know what the iPost says in a patient who's actively admitted at Mary Greeley Medical Center, you look at the orders. I mean, if that's what you want to know what medicines they're currently on, you look at the orders, okay? So the iPost order set is universally and instantly available if you're an inpatient at Mary Greeley, like any other order is. Medicines, diet, so on and so forth. But the point is that when the patient is dismissed, and just like you said, those orders disappear, okay? Our fallback is to print out on paper a list of the medications that the patient should be taking, okay? I mean, the iPost is essentially the same idea. You're now leaving the hospital, the order set that was written, which was pertinent to that hospitalization, like medication orders, disappears. And so they have to take that order set to the next institution where they go.
If you think of somebody going in and out of long-term care, it sort of goes with the transfer sheet. Because it's part of their medical orders.
Okay, I'm not familiar with that portion. So if they're at a unskilled care and they move, like at Green Hills or whatever, and they move into skilled care, they have papers or orders or forms that go transfer from their apartment to the nursing care center?
Sure.
Okay.
I mean, physicians have to sign those orders all over again.
So essentially, they're going to have an electronic copy of this that will come with them and disappear when they leave.
Well, but I don't have access to Green Hills skilled care when the patient's admitted to Mary Greeley. So just like I need a copy of their medication list, I need their iPost, so that as I admit that patient to the hospital, I can order the correct medications and put the iPost orders into Mary Greeley's order set.
Okay, so a nursing home doesn't give you a medication list? The patient has to have it with them when they come in?
No, I mean, in the same sense that, the nursing home sends it along, the nursing home will put the patient's iPost with the packet of
Okay.
information they send.
That's what I meant.
Yeah,
Thanks.
you're welcome.
I think one of the things that if you look on into the literature about the research that was done behind this, one of the things that was demonstrated by the Eastern Iowa Project was that they did a survey of physicians after the cases where iPost was used, and in over a third of the cases, the physician said the presence of the iPost changed how they managed the patient. And that's significant. A third of the time, it changed how you managed the patient because you knew, as an order set, what the orders were for that patient. They would have been more aggressive had they not had the iPost order set that traveled with the patient. Yes.
I think this is a great thing. I'm excited about seeing it implemented. I got to fill out my iPost. I want everything done, incidentally.
Okay, we'll make a note of that.
I had a question about one of the slides. The law shall not be construed to condone, authorize, or approve mercy killing. That makes sense, or euthanasia. But then it says, or to permit any affirmative or deliberate act of omission to end the life other than to permit the natural dying process. My understanding is that if, like, for example, you're dying and you don't want IV fluids or even oral hydration, an NG tube, all these things that we can do to make you live longer, that you're within your rights as a physician and you're within your rights as a patient to decline those kind of interventions. I wonder if you could just speak for a few seconds about that, Larry.
I think it's, first of all, it's legislative talk. And so, like a lot of legislation, you say it twice. You sort of say it once in the positive and once in the negative. And so, if you think of it in those terms, there's nothing about that phrase or Iowa law which is different from your understanding, which is that an adult can decline any intervention from that standpoint. So it's just, I hate to call it legal speak, but it's an Iowa law, so it's not necessarily meant to be the height of philosophical clarity. But it doesn't change your understanding, which is correct.
We have a question about clinical application. So starting from when we should address this, when the patient come to the clinic or only in the emergency room?
In which is it? The advanced directive or the iPost?
When we should have them fill out, when they come to see us in the clinic as a appointment time, or only when they're admitted, or when should we implement this form?
Whenever you and the patient are having a conversation about, would you want this done or not done? And Dr. Killian gave me a great example. There was a patient who had just been discharged from the hospital, but came back to her office from the nursing home. And, part of their discussion was, do you really want to be hospitalized again? And frankly, that's one of the major things that was discovered in the pilot project was how many times patients who were repeatedly hospitalized for really conditions that couldn't be really reversed ended up not being sent to the hospital, time and time again. So the answer to your question is both. So if you're sitting down and visiting with a patient, and oftentimes with the family, maybe it's after a recent hospitalization and the kids have come into town and they want to talk about, gosh, mom just doesn't want to keep going through this. Then filling out an iPost in your office would be appropriate. If it's the discussion at the end of a hospitalization and family and patient say, we just don't want to do this again, then it would be appropriate. So either location. It's really when the questions that the I-post raises are relevant. Chronically ill, repeatedly hospitalized, frail, elderly. That's when the discussion is relevant, whether it be in the office or in the hospital.
Am I going to be faulted if I don't do this?
No?
Okay. In the long-term care facility, as she mentioned, is there a law for them to fill out in addition to the advance directive, or it's just optional, just like here?
It's optional, not required. Once the document's completed, it has legal standing, but it is not a mandatory document.
Thank you.
I think a natural conversation would be when someone fills out their medical directive or their medical power of attorney for the first time, that should be a decision tree right there. Do they fit one of the categories of frail, elderly, serious and complex, terminal illness, life-threatening illness? If that's the case, they should be offered the opportunity to fill that out at the same time. And they're going to need help because it does require someone in healthcare who has knowledge of the patient, knowledge of their condition, who can actually help them understand the consequences of the options. Good question, thank you.
And it's kind of like we had this planned here. So in light of that question, what if you have the patient that miraculously turns around
Remember
and you've got this I-post and they bring it in with them 3 years later and they're just fine?
if the patient is able to make their own decisions, they make their own decisions.
Even if they're not frail or terminal or anything anymore, that I-post still is relevant for them?
If the patient is able to override anything in the advance directive, whether it's MPOA, living will, 5 wishes, I-post, if they're able to override that and are of sound mind, they can do that at any time. Just like any other directive.
So I can hand my I-post over to you?
You cannot.
And I'm just fine?
You're not frail, elderly?
No, I was when I filled it out.
Gotcha. It belongs to the patient. It stays
But
with the
3
patient.
years later, I mean, I think about a patient we just had that went many years between very dramatic health issues. In that interim time that she was doing well, could she have handed that I-post over?
And again,
walking in like me and being
I think that's a good illustration of why is it that we don't just scan these into the EMR, okay?
right.
If I were that patient and I experienced a miracle and my health was good and I had this I-post, I would tear it up. If it doesn't exist, it doesn't exist.
Right.
And if we haven't scanned it into the electronic medical record,
Sure.
that's it. So the whole point is that this is a document that patients carry with them. They can always revoke it by destroying it. It's only them that controls the document. We don't. And so, again, to scan something into the record and to have someone stumble across it when it's not even pertinent to what the patient's wishes are at the time is a perfect example of why you can't scan these
That could
things
be
into the medical
catastrophic.
record.
Yeah.
And that's also the value of the bottom section on the second page is reviewed dates. So if it's reviewed and this person has a miraculous change in condition, the physician can say, hey, you don't really meet the conditions for this anymore, let's get rid of this. There was another question. Yes.
What about if you filled this advanced directive out 10 plus years ago, one of these McFarland ones? Is it still sitting in McFarland medical records?
It is.
Okay.
And if you want to change it, it's always a good idea to update it.
Well, I looked at it again, but I...
Yeah,
changed
right.
it.
But
Yeah.
no, that is a document which is still in the electronic medical record. Now, there are some of those components that do have legal standing. So, for instance, the living will, which is an Iowa document, has legal standing. The designation of a person for a durable power of care for healthcare matters has legal standing if you fill it out correctly. So those documents have legal standing.
And those of us who look for advanced directives in Epic, which would be, Hospice does that all the time, we always look for the one with the most recent date, if there's more than one. I'm sure other people do that as well. Yeah.
I am not a physician or a signer on that document, but as a physical therapist, we see the repeaters all the time.
Sure you do.
And is it appropriate for me to write in this physician sticky note, I-post? Would you consider I-post for this client?
Yeah, we hope that both as palliative care becomes a reality at Greeley Medical Center, advanced directives becomes more emphasized, I-post becomes more emphasized, that anyone who has contact with the patient should be able to say to the team, you know, I've walked up and down the hall with this lady. I mean, you probably have longer conversations with some patients than I do. If I pop in and out of the room or chat with the family and so on, I mean, there's nothing like having to walk. You know, you talk about something and people are willing to share. So the biggest mistake is to think that somehow your voice doesn't matter. So that would be very appropriate.
One of the other things that happened in the Eastern Iowa study was that more of the general population had advanced directives after this was started. Because you can't have an I-post without an advanced directive because it complements it. So that was also another positive thing that really helped people stop and think about what happens if I can't make my own decisions. We have gone over our time, so
Oh, sorry.
any last questions?
Class dismissed.
Thank you.
We need one of those bells.